But in clients that have that sensitivity at the tibiofemoral joint, for example, cramping. But again, not easy. But again, you can see that we're getting most of the rotation through the tibiofemoral joint here now. Okay, so when I'm trying to get tibial rotation, I want that femur to stay fixed. I don't want that femur to go into the same direction. So that's why I want the tibia to move first, then the femur. And then once the femur is in the same direction as the tibia, in adduction and internal rotation here, then we're going to get a lot more challenge on that tibial external rotation because the femur is actually moving in the opposing direction. And then once the tibia has moved through its available excursion, then we can bring the femur with it. Same thing into internal rotation. We're going to get a bit more of a genuine internal rotation of the tibia there because the femur is not going to come in the same direction as it. Okay, but helpful to just increase that demand on the hamstrings because now you're getting a little bit more load being shared between the medial and lateral portion of the hamstrings. Okay, but just a nice way to add a bit more of a coordinative demand to your hamstring loading. One thing to note here, like I said earlier on, is that if you have clients with meniscal issues or have clients with sensitivity at the tibiofemoral joints, sometimes this hamstring bridge position can be sensitive because in this 90-degree flex position at the knee, if you extend here and then drive down through here and then lift up. So in this position now, most of the demand conceptually is on the distal hamstring. So there's a lot more concentrated demand on the knee. So sometimes we'll complain of like irritation through the front of the knee or the medial lateral portion of the knee. And it may be secondary to the distal hamstring's inability to handle that load or the fact that the knee can't tolerate that load in isolation. So then what we can do there, if we still wanted to load the hamstring, we would just have to extend the hip and knee. So now when the knee extends a little bit more so and he drives through the heel now and then bridges that pelvis up, you probably feel a bit more load across the whole hamstring now, maybe into the proximal hamstring belly. But now you can hopefully appreciate that that's not concentrating that motion at the knee now. You're getting some load to the hip extensors as well. Does that make sense? So knee flex at 90, concentrated load at the knee. Knee extends, hip extends. When you drive down, you're getting hip extension and knee flexion. Knee, hip at 90, knee at 90, concentrated knee flexion. So if someone has issues at the knee, just consider that as well, that maybe if they have discomfort there, it's not that you have to avoid that motion completely, it's just that it may tell you a lot about the ability of the muscular tissues that are engaging in that task to tolerate that load in isolation. So just like the same idea between the local and coordinative strategy, that's more of a coordinative strategy now because we're coordinating knee flexion with hip extension. That's what the hamstrings do. They flex the knee, they extend the hip. So if they can't tolerate load just via knee flexion, then we may have to get the rest of the hamstring to help out. And then we can come back to more of an isolated load through the knee flexors, the distal hamstrings. Does that make sense? Yeah. So